We're going to talk about different types of analgesics today, and you can see from the happy faces and the sad faces that you can have such a continuum of pain, and pain is what the patient says it is. And you have analgesics that relieve pain without the loss of consciousness. There are different subcategories that we can give the patients for pain. You can use opioids, NSAIDs, and other associated drugs like anticonvulsants. We use gabapentin for to help somebody with diabetic neuropathy when they have a loss of sensation in the lower, usually it's in the lower legs, and the glucocorticoids that are anti-inflammatories, and like a patient with rheumatoid arthritis may be taking them with an exacerbation of their pain to relieve them. So there are many types of painkillers. You can see from the picture that there's different ones. Hydrocodone, you want to be careful with that one that you don't get it mixed up with oxycodone, and OxyContin is longer lasting. And there's different coating. We use that for cough. Sometimes they'll put it in a different type of cough syrup. And so usually the moderate to strong pain that the patient complains about, we use opioids for that. And pain, going back to your fundamentals, it's an unpleasant sensory and emotional experience associated with acute and potential tissue damage. It tells the person that they've got an injury, that there's something wrong in terms of tissue injury. Pain, though, the definition is what the patient says it is. And if they say that they're in pain, you should believe them. Pain is the fifth vital sign. It's individual in terms of a pain threshold, what the patient can stand. And the mu opioid receptor gene controls the number of mu receptors that are present. And so there is a genetic component to pain. And the individual has a large amount of mu receptors, the pain threshold is high, and the pain sensitivity is reduced. And so it is associated with tissue damage. Pain is one of the characteristics of inflammation. There's important definitions in terms of pain, and you know from the introduction that definitions are very important to understand. So really take some time to give yourself examples with this to understand it. So tolerance, amount of pain a person can endure without having it interfere with their normal functioning. Different people have different tolerances for pain, and it varies from person to person. It's very subjective, but it's influenced by age, gender, culture, ethnicity. Like, for instance, in terms of culture, Irish people are very stoic. Some people, like Italian people, tend to be a little bit more emotional about their pain. Attitude, previous experiences with pain. If they fear that something's going to happen, and they're going to be very uncomfortable, that interferes. The anxiety level, and also specific circumstances. Then you've got the term addiction, chronic neurobiological disease whose development is influenced by genetic, psychosocial, and environmental factors. And there's psychological dependence as well. Usually the person, it interferes with them occupationally, socially, for the individual, and they want more of it. Acute pain is less than 6 months. Chronic pain is more than 6 months. It's a difference in terms of acute and chronic. And acute is usually sudden in onset too. Subsides when it's treated, typically, like I said, less than 6 week period. But usually the definition is less than 6 months. Chronic pain, persistent, is recurring, difficult to treat, longer than, and your book says 3 to 6 months, but most of the time, in terms of the American Association of Pain, they say more than 6 months. Breakthrough pain. Pain occurs between doses of pain medication. Especially you see this with the cancer patient. You give the person like maybe IV morphine, and they still need maybe some an oral analgesic that might help them. Pain threshold is the level of stimulus needed to produce the sensation of pain and the patient perceiving it. And referred pain, it occurs in another area. Like, for instance, with the person with the myocardial infarction, for the males. Now, for the females, the patient with an MI usually has some very vague symptoms. But the patient who is male has it starts in the heart, but then goes to the jaw and down the left arm. But women often don't have those very specific symptoms. Theirs are more vague. And then, like you can see, this is the definitions in your book, but chronic pain usually it goes by 6 months, like you said. So an example of acute pain would be somebody after a post-abdominal incision, for instance, or a surgical incision that's inflamed, irritating the nerve endings that are in the tissue. The edema is pressing on surrounding organs, causing some ischemia and therefore some pain that way. So there's different mechanisms that are going on with that, but it's going to be short-lived. And the chronic pain is going to be persistent and recurring, like somebody with rheumatoid arthritis or osteoarthritis. Nociception is the sensory pain receptors are activated, and they can be activated by mechanical, like pressure from like a cancer, or the cancer cells multiply, they press on surrounding organs. And thermal, like with heat or burn, or chemical stimuli. And chemical stimuli can be like inflammation, your chemical mediators that go to the nerve endings and irritate them and cause sometimes a burning type of pain. And when tissue damage occurs, the injured cells release those chemical mediators that irritate those exposed nerve endings. Pain originating from a tissue injury is called nociceptor pain. And usually you also have, when we talk about somatic pain, it means structural tissues like bones and muscles is coming from. Visceral, we're talking about organ, deep organ pain. A lot of times visceral pain is more of a dull pain because it's so deep. And so what's the difference, for instance, between nociceptor pain and neuropathic pain? Well, the pain is due to an injury in the peripheral nervous or central nervous system. For neuropathic pain, the patient usually complains of burning, tingling, electrical shocks in the affected area that's triggered by light touch, like a patient with diabetic neuropathy. What's phantom pain? Somebody who's had their leg amputated usually still experiences and remembers the pain from that particular area before it was surgically removed or traumatically removed as a result of an accident. And so a lot of times there's that particular pain too. It shows you the mechanism by which irritation and the perception of pain occurs. And the first question here, in terms of question number 1, which of the type of pain with the cholecystitis is they talking about? He states the pain is felt in his back between his scapula. So somatic can be somatic pain, referred pain, visceral pain, or neuropathic pain. And the answer is B. It's cholecystitis. It starts in his gallbladder, so starts about in his abdomen, the right upper quadrant, and then he feels it in his back between his scapula, so that's definitely referred. And then the World Health Organization has a 3-step analgesic ladder. Usually in terms of, and we have to be careful as nurses that we treat our pain well and that we don't undertreat it, which a lot of nurses do. 75% of clients complain that they don't have relief from their pain. And just because we've given them an analgesic, we got to go back and evaluate it. That's one of the biggest things at Unity Point is we don't have the people going back and evaluating it. And so undertreated pain, what are some of the reasons? Patients' willingness to acknowledge pain. Sometimes they say, well, I don't have any pain, or they don't want to tell anybody. The patient's inability to be able to describe the pain, the nurse's inability to measure the pain, not using the proper tools for that age group. Like, for instance, if you were having a client who is adult and is alert, you could use the numeric scale. However, with a young child, you might want to use the Wheeling-Wong faces for them to point to the face. Or for an infant, you'd want to use the baby scale, where you go by how much crying and what are some of the restless movements and so forth. And for that, it's undertreated pain is caused by non-use of regular assessment tools and going back and making rounds, making sure where your patients are at with their pain. The attitudes of the care team, oh, she's always asking for something, I'm not going to go back there. Unwillingness to believe the patient's report of pain, they're not having any pain. And an inaccurate knowledge of addiction and tolerance. When the patient physiologically needs the medication, they are not taking it for psychological reasons or the effect of just being high or sedated, and so that they are taking the pain for a reason, and when that is not addiction. And prescription of undertreatment is also caused by a prescription of an inadequate analgesic dose. So you can see from the World Organization step ladder, we start with the lowest kind of on the level based on their pain, but also to see what works. So non-opioids at first. If the pain persists, then we move to the opioids, maybe with a NSAID or without it. But then if it still persists, then definitely, if it's moderate to severe, we would go to the opioid. And you can see some of the pain assessments tools. There's many different types. You've got the descriptive type, where you ask the patient to describe the pain, none to worst. The numeric type, where 0 to 10, 10 being the worst pain you have, and give me a number. Or the faces, the happy faces to the crying faces. Somebody who has trouble understanding the verbiage and numbers, that would be a good pain scale to use. So depending on what your patient's needs are, you would pick the scale best for them. And then the happy faces, from the happy to the crying faces, are recommended for children 3 and older. And then you've got the crying. The cries is a tool that requires oxygen to keep the saturation above 95%. You look at the vital signs to evaluate pain and their expression and their sleeplessness. And that would be for an infant. And then the FLAC pain scale, behavior scale, is a nonverbal for children 2 months to 7 years of age. And it's based on, as you can see there, the face, the legs, the activity, the cry, and the consolability. And we usually use it for acute surgical pain. So physiologically, the other thing that we use for assessment is the vital signs, but you don't want to, like you said, subjectively, in conjunction with that, if you have a patient unconscious, if they're getting really restless, or a patient that doesn't have, has dementia, you would, sometimes the changes in vital signs you'd expect, increased respiratory rate and heart rate and blood pressure, and that should be part of assessment. Other responses when the patient has untreated pain, they get the stress response, urinary retention, fluid overload, electrolyte imbalance, a high blood sugar, pneumonia, atelectasis, anorexia, paralytic ileus, constipation, confusion, and infection, and weakness. And so there's many different sequelae to untreated pain. Opioid drugs, you can see, treats the moderate to severe pain. An example of agonists, a mild one is codeine, hydrocodone. Strong ones are morphine and hydromorphone. Oxycodone, which we use at fentanyl, is very strong. Methadone. Meperidine or Demerol we don't use very often because the metabolites accumulate in the system and can cause seizures. As a matter of fact, a lot of acute care hospitals do not use it. We do not use it as one of the opioid drugs at Unity Point. And how it works, opioids is attached to the receptors in the central nervous system and alters the response to pain. Analgesics, the mechanism, as you can see there. What does agonist mean? This is kind of a review from the fundamentals, but a substance binds to the receptors and causes a response. And our goal in terms of opioid analgesics is to relieve the pain, of course. And what does antagonist mean? Well, when you have like an overdose of an opioid, you might use an antagonist like Narcan that binds to the receptor and prevents or blocks the response, a non-analgesic response. And what does the term agonist-antagonist mean? A partial agonist is another synonym for it. Substances that bind to a receptor cause a partial response, not as strong as an agonist, but so partial, half of a response. And the reason why I put the picture of the key and the receptor, it's like a lock and key. I always think of the insulin. So you got your drug there, and neurotransmitters work the same way. So your insulin or your drug very specifically has receptors on the cell wall, and to open it up and to cause its effect, it binds to particular receptors and then gets into the cell that way. So unlocks the door, so to speak. Equi-analgesic or comparable results. Sometimes when you use different analgesics, you can get the same results, but if you're using a weak one, you might have to use more of it than the stronger one. So an example of that would be like I showed you morphine 10 milligrams give to a patient, but later with hydromorphine 1 milligram, the patient could receive 17 milligrams of the morphine, and that would be equivalent to hydromorphone. Most of the time when we give morphine for a couple of days around the clock for a patient, a lot of times you'll see that they might complain of nausea, so we have to give an associated drug with it. And a lot of times they might complain of itching, so we have to give, so for instance, for the nausea, on Danzatron, we give that one. And then for the itching, we might give the Benadryl. And so how does the morphine act? Well, it acts on mu receptors and to a lesser degree on kappa receptors to produce the analgesic, like the lock and key effect. And it causes some sedation, and because it acts on the central nervous system and reduces bowel activity, causing constipation. So that if you're looking for an adverse effect, a lot of students would tell me constipation. Well, that's correct. And so codeine is a cough center suppressant. A lot of times, because that side effect, opiates are used also not only for pain but the treatment of diarrhea. They can be given so many different ways, orally, IM, IV, sub-Q, and epidurally. And sometimes they're given as part of the anesthetic protocol, so with other anesthetics to cause balanced anesthesia. You can see the opium comes from the poppy, and it lists the constipation there. And of course, time you're giving an opiate, you're going to watch for respiratory depression. And that's the basis for the naloxone or the Narcan, this is the trade name, for that too, it reverses that respiratory depression. So the morphine, the adverse effects, respiratory depression is definitely one that you watch and assess the patient for. Sedation are effects of the mu activation, and the K receptors activation leads to the analgesia and the sedation. What nursing interventions could I do for each of these? Well, respiratory depression, I'm going to monitor the vital signs. If the respirations get less than 12, I'm going to stop the drug. I'm going to notify the provider. I'm going to use naloxone and have resuscitation equipment available. I'm going to avoid other central nervous system drugs. So you'd caution the patient not to use alcohol. Constipation, I'm going to increase their fluids. 2 to 3 liters is adequate, and fiber and physical activity, exercise. And you could administer a laxative or a stool softener on a regular basis, and of course teach them to watch out for that. Orthostatic hypotension, you going to put them on fall precautions because as they change positions they could fall, especially an older patient. So ask them to sit down and then take a few minutes and then stand up. Assess the blood pressure in 3 positions to assess them for it and tell them to change position slowly. Urinary retention, assess their INO. Assist them to void every 4 hours if they're not able to do it independently. Assess their bladder with a scanner. Avoid anticholinergics, which will increase the urinary retention. And anticholinergic effects go with a lot of your psych meds, especially your antipsychotics. That's a side effect of that. Your older antidepressant medications like your tricyclics. And sedation, again, that is an anticholinergic side effect, so all of those drugs I just mentioned with those effects. And so you'd ask the person to avoid hazardous machinery and driving. Nausea and vomiting, you could give them some what you might know as Zofran, and the generic name is ondansetron, and it's an antiemetic. And you'd watch the patient for pupil constriction. Oral morphine goes through the first hepatic pass, and meaning the liver metabolizes the drug before it's available to the rest of the body. And only a very small amount crosses the blood-brain barrier. Think of it as a brick wall, but some drugs do get through, so it has little pores that they can get through. And it has a very short half-life. 90% of it is excreted in the urine, so especially somebody with a renal kidney problems or failure is going to have it stay in their system longer and have an increased effect. Morphine crosses the placenta and is excreted in the breast milk, so you'd weigh the benefits and risks of the patient getting it, and you'd want to keep the doses small because you're essentially also sedating the child and the fetus. The opiate analgesics contraindications, of course, if they're allergic to it, severe asthma, emphysema, or head injuries, where asthma with an emphysema where they have a low SAT-O2 already, and then you are giving them a central nervous system depressant that could cause some respiratory depression. Pregnant women, there's a risk of dependency of the fetus. Obese person, it is metabolized slower and so accumulates in the system. Those with hepatic or renal disease. Biliary surgery, especially for morphine, is contraindicated after biliary surgery and with premature infants. It's used in caution with someone with respiratory insufficiency, elevated intracranial pressure, morbid obesity, sleep apnea, paralytic ileus, and pregnancy. It's going to interact with central nervous system depressants, anticholinergic agents that have that effect of sedation, and antihypertensives. So assess the pain regularly using the tools, and then go back and assess it after the pain medication is done, whatever what is has reached its peak, and afterwards go back to when it reaches its peak, check whether it's effective or not, and then go back and see if later on if they need more of it when its duration is almost up. When you go and assess it, they may need more pain medication with breakthrough pain, and so you want to be careful of that. Or you want to offer them non-pharmacological measures to help the pain, like back massage, acupuncture, acupressure, art therapy, hot and cold packs, depending on, like if you've got inflammation, you put a cold pack locally. Hypnosis, meditation, prayer, music therapy, pet therapy. A lot of people respond to that. Physical therapy, transcutaneous electrical nerve stimulation, which I think for chronic pain is very effective. Relaxation exercises, touch, distraction is all something that can be affected. So these are non-pharmacological things that nurses can't do without a prescription, and we should be thinking about that all the time. You want to monitor the patient's vital signs because that is affected. You want to double check the opiate doses, nurse check to avoid an overdose. Double check if they have a PCA pump, if you're changing the settings with 2 nurses as well. Have naloxone and resuscitation equipment available if they have respiratory depression. For cancer patients, it's always good to put them on a fixed schedule. And a lot of times if they are have a very advanced cancer, referring them to hospice nurses is very appropriate because they will help with the patient with their pain. They're very good at that. And withdraw the meds slowly over a period of 3 days so they won't have any withdrawal effects, especially when they have been on them for several days. Augment them with non-pharmacological interventions as well. From the question, person has an appendectomy, asthma, allergies to shellfish and iodine, so they're going to have allergies to contrast dye. Manage your postoperative pain. The physician prescribed patient-controlled analgesia, the PCA pump, with hydromorphone, and which vital sign is of greatest concern? And that would be D, because it can cause respiratory depression. And if the patient has a history of asthma or allergies, she will be receiving a drug that will depress those respirations, so put her more at risk. This question, patient has metastasized bone cancer, has been on fentanyl patches for pain management for 3 months, has been hospitalized for tests and told the nurse that his pain has become unbearable. The nurse is reluctant to give him the ordered pain med because the nurse does not want the patient to get addicted. What do the nurse's actions reflect? And that would be D, the undertreatment of failure to manage the patient's pain properly. Patients with severe pain, especially metastatic pain or bone pain, need higher and higher doses of analgesic. And the nurse is responsible for ensuring the patient receives adequate pain relief. Then you've got the opioid antagonist, so it's going to cause the opposite effect of what the opioid did. It's going to interfere with the opioids by competing with the receptor. So in other words, you're trying to put your key in the lock with the morphine, and somebody else comes and puts their key, and you can't put 2 keys at the same time. And so that's what the naloxone or the Narcan does, and it can be given IV, IM, or sub-Q. It is the drug that is going to be, that they're considering giving to the firemen and the police and so forth, because we're in an opioid crisis and people are abusing opioids because they'll doctor shop, they'll go to different places for prescriptions, and it's a national problem. And so it has no effect when you have the Narcan, when you have an absence of opioids. You don't get any effect. Reverses respiratory depression as with an overdose, and it's not, as you can see there, it's not given orally. What can occur with large doses of Narcan in a person with an opioid addiction? withdrawal symptoms. The Narcan, because of the fact that the half-life of Narcan is less than the half-life of the opioid, you have to go back and give them some more and reassess for the return of respiratory depression every 2 hours and monitor them up to 72 hours after their use, because you may have to repeat the doses and the respiratory depression may reappear. So you want to watch them for that. It does have some adverse effects, as you can see: tachycardia, tachypnea, or an increase in respirations, and an abstinence syndrome. You can see from the cartoon there what the side effects are. It's an antagonist, so it's going to compete with the receptors. Here's a patient with opiate withdrawal. Or opiate, another synonym for that is opiate abstinence syndrome. You can see the patient has hypertension. The patient has anxiety when they withdraw. Patient has anxiety, irritability, chills, hot flashes, rhinorrhea, diarrhea, confusion, abdominal cramps, vomiting. And so you want to keep assessing the patient and also be watching with your peers too if they have any symptoms of opiate withdrawal, because we have more and more nurses who are medicating and using opioids on a regular basis. It shows you the timeline for opiate withdrawal. So even if the patient is not having any type of physical symptoms, you can see that when you're taking care of a patient over at Robert Young, that they will continue to have those cravings and depression for up to a month later. It takes that long for it to get through their system. And the codeine is an opiate. We use it especially for cough. It's not as potent as morphine. It's about 1/20th as potent, but it relieves, if it's used for pain, relieves mild to moderate pain. And it, like I said, is used, also classified as an antitussive, because it suppresses the cough. Most opioids, with the exception of meperidine or Demerol, has an antitussive, a little bit of a antitussive, but not as much as codeine effect. And many opioids possess antidiarrheal effect, cause constipation. And so somebody with this, of course, you're going to watch for constipation, have them take deep breaths, assess their lungs, and increase their fluid, and that will help with the cough too. Fentanyl is available in patches, IMPO lozenges. It's used to treat moderate severe pain. It's very potent. So it's a dose, a very small dose of 0.1 milligrams. IV is equivalent to 10 milligrams of morphine. So it is quite potent. And it's becoming a drug that a lot of patients are overdosing on. Hydromorphone or Dilaudid is very potent as well. 1 milligram is equivalent to 7 milligrams of morphine. It's fast acting, short duration. It's 6 times more potent than morphine, with fewer hypnotic effects and less GI distress. Used in a variety of routes. And when you give it IV, you want to dilute it in 5 milligrams of normal saline and give it over 5 minutes. So that way you're giving a milliliter a minute, and monitor the respirations carefully. Meperidine or Demerol, like he said, is taken off of a lot of lists in acute healthcare facilities because it can accumulate in the system. It's metabolized in the liver and excreted in the kidneys. And so its metabolites, especially for folks with those problems, can accumulate quite quickly and in a short time. And so that neurotoxicity and seizures can occur, especially with renal disease, because these metabolites can accumulate. So a lot of people will not use it. But it is very effective for biliary colic. It's got an antispasmodic kind of effect to it, and so it is, unlike some of the other opioids, and it can be quite helpful there. Methadone hydrochloride is also an opioid analgesic. A lot of times we use it for detox treatment for opioids like heroin addicts, and then they would take methadone. They would get a regular doses of methadone. It doesn't interfere as much as heroin with their occupationally and socially in terms of activities, and so the methadone doesn't interfere with their activities of daily living, and so it is better. It still has withdrawal effects and so forth if they come off it, but it doesn't interfere with that. So the person can go ahead and go on with their life. It has a prolonged half-life, but it's caused a lot of unintentional overdoses and deaths. It can cause cardiac arrhythmias as well. Then the non-opioid analgesics. Tylenol, acetaminophen, has analgesic and antipyretic effects. One of the things is that they're really looking at the amount of acetaminophen a person can have. A lot of times there'll be oral pills where maybe it'll be hydrocodone with acetaminophen in it, like a Percocet, and you need to realize what the generic is, what the ingredients are in it, because that acetaminophen that they're getting with that pill adds up with just a plain Tylenol. So you want to be careful how many milligrams they're getting. We usually allow 4,000 milligrams a day, and you should give no more than that for an adult. However, they're re-looking at that and thinking about bringing that down to 3,000 because an accumulation in the system can cause liver dysfunction. So they're very rare for you to have adverse effects with the drug. It's pretty safe. So a lot of people take a lot of Tylenol, and then in combination, like for instance, they might take a combination cold medication that has Tylenol in it too. And so you have to be careful of that. And it's an alternative for people who can't take aspirin. The way it acts is it slows the production of prostaglandins in the central nervous system, but it doesn't have any anti-inflammatory effects like the aspirin. So like you said, the dose is 4,000 milligrams per day, the limit. A person with undernourished should have 3,000 a day. And a lot more of the books are saying that we should lower it to 3,000 milligrams a day and 2,000 for older adults and those with liver disease. You want to watch for acute toxicity. Early signs are the nausea, vomiting, diarrhea, sweating, abdominal discomfort. And that could be hard to know what the cause is because there's such vague symptoms. But too much acetaminophen can lead to hepatic failure, a coma, and death. So we want to be aware of the amount of acetaminophen that the patient's taking over the counter and prescription. So when you get their med list, you also want to include over the counter drugs as well as prescription to go through with them. The antidote is acetylcysteine for the patient. And contraindications, drug allergies, liver dysfunction, possible liver failure, and a G6PD, which is an enzyme deficiency. And of course, because it causes liver dysfunction, somebody who's taking a lot of alcohol and other drugs that are hepatotoxic would want to avoid it. Like with warfarin, it increases bleeding. So you'd want to watch the INR levels. It can cause toxicity, so you want to keep it out of children's reach and lock it up. A lot of times children have the acetaminophen that are available in flavored tablets and liquids, and high doses can cause hepatotoxicity, and so we want to teach our parents that that can be a problem. Teach the adult caregiver not to medicate the child longer than 5 days without getting follow-up from a healthcare provider. Direct them to call the Poison Control Center if the child has taken an undosed dose of acetaminophen. And like you said, the recommended antidote is acetylcysteine for the person. It shows the NSAIDs, like an example of a NSAID prototype is ibuprofen. It can be a first or second generation NSAID. The first one inhibits COX-1 and 2. COX-1 results in decreased platelet aggregation and kidney damage. COX-2 interferes with decreased inflammation, fever, and pain. All NSAIDs have the analgesic principle effect with it, as well as antipyretic, so it takes care of fever, in other words, and anti-inflammatory, the pain with inflammation like a sore wound. So aspirin is an example of a NSAID who has all these qualities. NSAIDs cost more than aspirin. A full side effect of NSAIDs is gastric irritation. These drugs should be taken with food, at mealtime, or with a full glass of water to help reduce this problem. It shows you what the COX-1, the COX-2, and the combination do. The one, like you said, it results in decreased platelet aggregation and kidney damage. 2, decreased inflammation, fever, and pain. The newer NSAIDs block only COX-2 and not 1. And these drugs leave protection for the stomach lining intact, so they cause less bleeding, ulcers, and bleeding in the gastric area. But they still deliver relief for pain and inflammation. A COX-2 inhibitor, a second generation NSAID, is celecoxib. It doesn't prevent blood clotting. It does prevent some types of cancers, such as colon cancer. Fruits and vegetables also block COX-2 enzymes naturally and protect the colon from malignant growths. So lots of fruits and vegetables in your diet. It shows you aspirin. Aspirin is anti-inflammatory as opposed to your acetaminophen that is not. Anti-pain, antipyretic, and antiplatelet. A lot of times people take aspirin to prevent a myocardial infarction. It's so that platelets clump together. It prevents that from happening, so that keeps the clotting. If you've got atherosclerosis, that the blood cells are clumping to the fatty tissues on the inside of your vessels. You want to assess the patient for allergies. People do have allergies to aspirin. You want somebody who takes too much, can have tinnitus, vertigo, bronchospasms, urticaria, are some of the symptoms that they can have with the sensitivity or an overdose or too much of a salicylate. Certain foods contain salicylates also: prunes, raisins, paprika, licorice. And those who have a hypersensitivity to aspirin or salicylate products can be sensitive to other NSAIDs as well. In given in high doses, GI problems can develop in about 20% of patients, like bleeding, more so with aspirin than with ibuprofen. Talks about the salicylate poisoning. The salicylism is another synonym for that. The tinnitus, the sweating, headache, dizziness, and respiratory alkalosis, the hyperventilation can lead to. Reye syndrome occurs when the aspirin is used for fever reduction for children and teens who have a viral illness such as flu or chickenpox. So you want to avoid aspirin and use another ASAID like acetaminophen instead. You can get too much aspirin, resulting in dehydration, high fever, respiratory depression. They give usually activated charcoal to decrease the absorption, water, fluids, and reverse the acidosis with bicarb. Other adjuvant drugs that you can use to relieve pain, I mentioned the NSAIDs. Antidepressants can also treat neuropathic pain and depression. Anticonvulsants, neuropathic pain, especially gabapentin, that's at the bottom of the slide. Corticosteroids I mentioned, central nervous system stimulants, decrease sedation, supplement analgesia. Antihistamines cause sedation, relieves nausea and vomiting, and decreases anxiety. The question 4, patient with heavy alcohol use needs a medication for pain. The recommended maximum daily dose of acetaminophen would be B. The patient here is a heavy alcohol abuser, so is at risk for liver toxicity from excessive acetaminophen use. So their maximum daily dose wouldn't be 4,000, it would be 2,000. Feverfew is a herbal product that it also has anti-inflammatory properties to treat migraines, menstrual cramps, inflammation, and fever. But it can interact with aspirin and other NSAIDs as well as anticoagulants. So you want to, when you get a history, ask them if they're taking any herbal products as well. Then there's special issues. The PCA pump. A lot of times you want to watch for respiratory depression. They usually need to be alert to press the button for the PCA pump. However, sometimes family members do that for them. And they may be also reluctant. Another issue, they may be reluctant to report the pain and reluctant to push the button. So you always assess, get a history at the end of each shift from the pump to see how many times they've used it, and do they understand they're supposed to press the button? Are they able to? Are they alert enough to do it? You want to look at a lot of times people will not report their discomfort because they have a fear of drug addiction. So you want to watch out for that. You start at very low doses in terms of a healthcare provider, getting the patient on the best pain management, and then you titrate it up as needed. They can get tolerant to opioids, so you want to watch for that. If they're they've usually had the similar dose, but now it's not effective after a couple of days, you want to suspect tolerance. The use of placebos, a lot of times people go, well, we used to give, like, let's give them saline. They're not really having that kind of pain. We don't do that anymore. I'm glad of that. We always want to believe the patient when they say that they're in pain. And you want to be aware of the older clients, that they have a reduced renal and hepatic system, and so they need lesser dosages. We want to give them less than the usual adult dose. And watch out for breakthrough pain. Oh, I just gave them something for pain. Well, if they're still having pain and so forth, contact the healthcare provider so they can get something else too. Maybe an adjuvant medication, or consider a non-pharmacological pain management as well to help with that pain.